So, welcome to the show, Mark. Thank you for your time. How are you today?
Well,
I've been really looking forward to meeting you and to having this conversation, especially after seeing your incredible work at NavVis Healthcare. It's fantastic to have you here. So, before we dive into the conversation about the opportunities and the challenges in healthcare today, let me briefly introduce you to our audience of healthcare leaders. Hi, all. My esteemed guest here, Mark Oderman, is a Senior Vice President of Managed Care Contracting at NavVis, a trailblazing company in value based healthcare. NavVis is a high performing, team based, and technology enabled organization that transforms practices and improves lives for the better. So, Mark, today we're going to explore your business model, where you are today, where you want to go, and what's blocking you. Sound good?
of course,
So the first question I want to ask you, Mark, is how did your company start and what was the initial problem that you set out to solve?
the company began about 15 years ago, and it was started because of some inherent inefficiencies that are found or noticed between predominantly hospital health systems managing their patients. When I say managing their patients, what I mean is the efficiency and the redundancy between care management of health systems and providers. Usually, health systems have a larger per patient per month cost than independent providers. And there's no real compelling reason for that other than certain redundancies. So the company was started, and its name is actually an acronym for navigating and envisioning the ability to be able to be more efficient for health systems. That's predominantly our comfort zone and our highest penetration of clients. We have a few payers that are clients of ours. We own a handful of provider practices, but our true strength is within health systems, meaning hospital chains that own their own providers and the way that they manage their value-based contracts.
That's wonderful. So, what is the biggest growth driver for you this past year?
I would say that along the rest of the industry, there's immense upward pressure on costs and the efficiency mechanisms that are within commercial and Medicare Advantage markets. So rates are continue to exceed inflation by a factor of about 1.5 to 2, and utilization is up roughly 4 points over a normative annual increase, which we saw as an average of about 3 to 4% before 2022. And since then, that utilization increase has been closer to 5%.
That's a pretty good growth rate, right?
Not if you're trying to contain costs. No. So what you would want is a reduction in that fairly dramatically. But we've seen the introduction of GLP-1s, which are extraordinary new pharmacologics. They're also very expensive, and they're putting a lot of
Yes,
financial pressure on the payers. And so they take that
absolutely.
money and they only have a certain amount of money to manage total medical expense. And so that would hypothetically cannibalize some of the actual medical expense when I say medical as opposed to pharmacologic.
I
And
see.
that money simply isn't there anymore. So
So, if you could press a button and remove one operational bottleneck, what would that be?
that's hard to answer because there are many, many different bottlenecks. But I
So
would
many,
say that the
right?
largest barrier for our clients right now is capacity constraints. So ERs are very, very full. It's very difficult to have an efficient ER. Those members end up being rolled into observation and or inpatient status where they languish longer than they need to. So an average length of stay for a well-run hospital system is somewhere between 4.5 to 5 days. And each day costs approximately $900. So each
I
tenth of a
see.
day is quite valuable, and getting those patients out of the bed into a lower cost of care setting, which would be the objective, is difficult because payers tend not to have enough of a robust post-acute care setting network. So if a person is in hospital with sepsis and it's been 6 days, sometimes it's difficult for the hospital to discharge that patient into a skilled nursing home because there aren't enough beds.
I see. Yeah. So, how do you think you're going to handle this challenge in 2026? Do you have any ideas on what to implement?
So there are a number of strategies to implement for that, most of which good health systems are already doing. It's simply a matter of how effective they can be at that and the barriers to entry for them to be able to do so. So I'll paint a scenario for you. A given hospital has 1,000 admits per month. So roughly 25% of those admits need some type of post-acute care, meaning they're either going to go to a skilled nursing home or they're going to go to home health at home. Let's say that they are with managed care organization number one, and that organization has only 15 different contracted skilled nursing homes in that vicinity. And all of those are running at a 90% fill rate. And so you have to start your discharge planning on day one. Now, you don't really know what day that person's going to go home. They might not be ready until day 7, but you need to prepare for it on day one. And you need to reserve a bed, which of course the skilled nursing home doesn't want to reserve a bed if they're not being paid to do so. And
Right.
sometimes those skilled nursing homes are given what we'll call unfavorable rates relative from one payer to another. So they may not reserve capacity for a particular hospital or for a particular payer. So these are the types of barriers that cause a longer length of stay, inpatient status than necessary. From a
So
payer
you need to
perspective,
be able to better manage your rates, right?
yes, but that goes back into the limited capacity of either the CMS rates as published, the Medicaid rates, of which there are no negotiation, or commercial, which there is plenty of negotiation, but that is inherently limited by the economic strength of the market that they serve. So, the citizen population contributes via withdrawal from their paycheck, right?
Mm-hmm.
And so that the economics only can go so far because it's an extraction and somewhat of the hidden tax, if we will, on a population for a given area. So hospitals, while they want to be able to subsidize their own margin, the corollary to that is the MCOs may not have the money because they've negotiated with employer A. And I'll just use this as an example. A large employer in a given metropolitan area has a contract with an MCO, pays for 5 years, and it has a 3% raise each year.
I
So the
see.
hospitals are demanding a 6% raise each year, which is a realistic ask for them because of the inherent increase of inflationary wages among nurses. Then it creates a margin squeeze for both parties.
Right,
That isn't
right.
solved immediately by increasing the hidden wage tax on employees via their inability to get a larger raise because the employer needs to subsidize the increased cost of their healthcare.
Okay, so then looking ahead, what are the biggest opportunities that your team needs to focus on then?
So in our business, we see some very radical different outcomes. So without sharing names of the particular clients, there are hospital systems that have a total cost of care for a given MCO. We'll call it 100%. And then they have a total cost of care for a different MCO. So same doctors, same hospitals, different MCO of 90%. So some of that difference in total cost is driven by the allocation of care management resources to that. So they're motivated by the structure of their contract and their relationship with that insurance company to expend additional non-medical efforts in care management. So they can drive down that total cost of care. At the same time, across town, there may be, well, we have provider groups that are independent that have a total cost of care for the same population in the same area, 2/3 the cost of that hospital system. So the answer is to help everybody be able to manage their patients the way that a highly efficient group can do so.
Yes, and speaking of efficiency, right? How do you think AI will be changing the healthcare landscape in the next year or 2 years to
There's
come?
actually some very fascinating administrative rules that AI is already using. So think of documentation. So a physician can now dictate. So that's a little bit old because that was based on dictation tools that might have been around 5 years ago. But now those sound dictation tools can upload it to a medical record and create the bill. So now you have less billers. It can submit the bill. and it can do an appeal for the bill.
Huh?
The 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 claim is now filled in by AI. It gets sent to the MCO. The MCO, let's say they reject it for whatever reason, for lack of documentation. The AI on the provider side can now read the file, send the file out. So now we have dictated medical record that's not in a claim because it's not turned into CPT and heated HCPCS codes and such, and can appeal the denial. So all of those are very manual efforts historically. However, it's becoming an arms race between one side and the other, that the payers using AI to more effectively, I won't say effectively deny, but effectively pay the accurate type of payment for the accurate type of service. Whereas a provider side may not be providing substantial evidence to necessitate the level of service of which they do. So
I
there's a little
see.
bit of an arms race on both sides to see who is getting paid accurately and whether or not the services rendered actually match the amount billed. As a simple example, um, the vast majority of ER visits are level 4 and 5. Vast majority.
Got
Level
it.
1 is something very simple. Level 2 is, I forget the amount of minutes. I think 20 minutes. Level 5 is, it should be very serious. Most level 5 should mean that you should go into the an inpatient status afterwards. Level 4 is about 45 minutes of a provider time.
Got it.
So if you have a lot of level 4 and you're discharged, there's a reason for the MCOs to suspect payment integrity on that, or perhaps they're rounding up. So the way to check that was to look at the medical record dictated by the provider to substantiate it as in fact level 4. Simple example, but that's kind of the headaches that are being caused and solved by AI.
So you think that maybe in 2026 you'll be able to implement more accuracy?
We're doing that now. Yes. Started
You
doing
are.
that about a year ago when the tools became more robust and reliable. They're improving all the time.
Yes, absolutely.
The ability to apply those is becoming more precise. And there's naturally a learning curve within the providers on how to use that and how to apply.
What would you say the percentage of your AI reliability is right now?
For revenue integrity, I would say
Mm-hmm.
somewhat over
75%.
most of the clients are using that now because candidly, it's become newly available. It's expensive to apply, but it's administratively much, much simpler. And it reduces the need for a lot of coders and appeals team, which would reduce your length of time of being able to receive accurate payment.
Yes. And do you think that the patients are okay making the transition?
Specifically with regard to revenue cycle, it's less patient affecting than other services. So there's some of this is very benign and unknown to patients. It's simply a matter of submitting the claim accurately and getting an accurate payment between the two parties extraneous to the patient.
I see. So you're using AI more on the back end office rather than the front end facing, right?
Well, for this particular example, yes, there are front end facing patient AI tools available.
Uh huh.
I didn't use them in this particular example. We're
Got it.
excited about some of the AI patient facing tools because a lot of the member engagement, so member engagement just meaning how we interact with patients, why we do that, when we do that, the methodology, how to manage a response. Some of those tools are becoming much more proficient.
Mm-hmm.
Still for administrative purposes, we don't use them and don't recommend them in the near term for medical decision making, but they're very useful if someone calls and says, "What's my benefit for outpatient copays?" Or "Can I get on the schedule for this doctor next week?"
Mm-hmm.
Things like that.
Got it. So scheduling or follow up, that type of thing, right?
Correct. Correct. We're optimistic sometime in the future that um, for internal medicine and certain specialties that these tools will be an efficiency enablement for the actual provider in the
Uh
way
huh.
that it is right now for radiology. So for radiology, they use AI to identify different nuances and different diseases within the read. It will present it to the doctor, but the doctor still has to confirm it. So they can
Right.
be much quicker rather than looking at the image, identifying the disease, dictating said disease. Now the disease is presented to them. They confirm its presence or absence, dictate into the medical record, and carry on. So much quicker. Ideally, this same type of application will be useful for primary care and at the moment, some of those tools are available, but they're not widely disseminated because of the liability purposes and such.
I hear you. So, what advice would you give to other leaders trying to navigate those similar challenges?
What we have found is that there's a lot of noise because there are a lot of different vendors and there are a lot of different applications, and they're not all interoperability, don't have interoperability. So interoperability being this the phrase word for how well does it integrate within your own EMR, the EMR of your system and your providers, and back into the MCO. And so without that interoperability, you might have a best in class product that doesn't communicate well with Epic or with a next gen or whatever EMR you're using. And so therefore it doesn't have smooth integration, which means that the uptake on it will be relatively low. Well, I'm making the conclusion that it'll be relatively low because that's what we see. Um, and so we suggest being slow and contemplative and recognizing that best in class products without best in class integration is not a best in class product. We have made the mistake of finding what we call best in class types of offerings without having the integration, and so not receiving the fruits of that reward.
Got it. I wanted to thank you for a great discussion and thank you for sharing your insights. Would you be open to another conversation maybe in a week or two?
Yes, of course.
Appreciate your time. I look forward to connecting again and best to you in 2026.
All right. Thank you, Jeannine.
Thanks so much. Bye.